about the drugs used in cases of pulmonary hypertension. So this is what this is the pulmonary blood vessel. So you will take this part. This is endothelium, then basement membrane, then smooth muscle. So we have three pathways. The first one endothelium pathway, the second one nitric oxide, the third one prostacyclin. So we have endothelium and basement membrane and then smooth muscle. So in endothelium, the endothelium pathway, there is release of proendothelin from the endothelium, leading to formation of endothelin 1 will go and act on a smooth muscle on endothelin receptor, leading to conversion of BIB2 into IB3 leading to increase the calcium. This increase in the calcium leading to vasoconstriction and proliferation. So this effect must be inhibited by what? By giving endothelin receptor antagonist on this receptor. So the second pathway, we have nitric oxide pathway. L-arginine will be converted into L-citrulline plus nitric oxide. So this nitric oxide will go to a smooth muscle leading to what? Leading to conversion of GTP into cycloguanosine monophosphate. So you want what? You want to increase the cycloguanosine monophosphate because this is responsible for vasodilation and decrease proliferation. Or given nitrates from outside leading to stimulation and increase in cycloguanosine monophosphate. Or you will inhibit conversion of cycloguanosine monophosphate into GTP to increase the cycloguanosine monophosphate. This inhibition by what? By giving phosphodiesterase 5 inhibitor, leading to inhibition of conversion of cycloguanosine monophosphate into GTP, leading to increase in cycloguanosine monophosphate. Then we have prostacyclin pathway. Arachidonic acid will give prostacyclin is responsible for increase in cyclic AMP like cycloguanosine monophosphate. Both of them will cause vasodilation and decrease proliferation. Or you will give prostacyclin analog which will stimulate increase in cyclic AMP leading to vasodilation and decrease proliferation. So we have these pathways in cases of pulmonary hypertension drugs. What are pulmonary hypertension drugs? We have endothelin receptor antagonist. So this is the pathway, endothelin pathway. We have proendothelin into endothelin 1 acting on the endothelin receptor leading to formation of more calcium leading to vasoconstriction and proliferation. So you will give endothelin receptor antagonist to inhibit the effect of endothelin leading to vasodilation. So competitively antagonize what? Endothelin 1 receptor leading to decrease pulmonary vascular resistance leading to vasodilation because you will antagonize what? Endothelin 1 which is responsible for vasoconstriction leading to vasodilation and decrease pulmonary vascular resistance. So the problem here with what? Hepatotoxicity for endothelin receptor antagonist. So the most famous one, the most common one is what? Busentan. What is Busentan? Endothelin receptor antagonist. Busentan, you must remember it. So hepatotoxicity, you must monitor what? Liver function test. So Busentan, endothelin receptor antagonist. Then the next one, phosphodiesterase 5 inhibitor. So we spoke about the effect of what? Nitric oxide pathway, and we said that L-arginine into L-citrulline and this nitric oxide will convert GTP into cycloguanosine monophosphate, and then you will inhibit conversion of cycloguanosine monophosphate into GTP by given phosphodiesterase 5 inhibitor, leading to elevation in cycloguanosine monophosphate, leading to what? Leading to vasodilation and proliferation. So here inhibition inhibition of phosphodiesterase 5 leading to increased cyclic guanosine monophosphate, prolongation of vasodilatory effect of nitric oxide. So we have nitric oxide, you will prolong the action of nitric oxide, or by giving nitrates from outside, elevation of cyclic guanosine monophosphate leading to vasodilatation. So which drug is so famous here? Sildenafil. So this drug was designed to be used in case of what? The pulmonary hypertension. But this drug caused the treatment for erectile dysfunction. It's contraindicated. This is the most important point here. It's contraindicated to give nitroglycerin or other nitrates because of risk of what? Severe hypotension. So we spoke about it. Given nitrates from outside leading to elevation cyclic guanosine monophosphate leading to vasodilatation, plus what? Plus you are given phosphodiesterase 5 inhibitor, which is sildenafil, leading to elevation of cyclic guanosine monophosphate more and more, leading to more vasodilatation, leading to hypotension, severe hypotension. So you shouldn't use sildenafil with what? With nitroglycerin. Then the next one, prostacyclin analog. We have this pathway, prostacyclin pathway, arachidonic acid into prostacyclin. Then prostacyclin will increase cyclic AMP, CAMP, leading to vasodilatation and decrease proliferation. Plus, given prostacyclin analog, which we are speaking about, leading to elevation and cyclic AMP and vasodilatation and decrease proliferation. So, prostacyclin analog was direct vasodilatory effect on what? Pulmonary and systemic arterial vascular beds, leading to inhibition of platelet aggregation. So prostacyclin analog does what? Causes vasodilatation plus inhibition of platelet aggregation. Which drug is so famous here? Iloprost, So if there is vasodilation, so of course the side effect will be what? Will be flushing. Plus there is jaw pain in case of usage of prostacyclin analog. Then the next one is what? Pseudoephedrine plus phenylephrine. So it's what? It's activating alpha adrenergic receptor in nasal mucosa, leading to local vasoconstriction. So it's used in what? In cases it's used as nasal decongestion. So pseudoephedrine or phenylephrine used as nasal decongestion because of its effect on alpha adrenergic receptor. It's agonist on alpha adrenergic receptor in nasal mucosa, leading to local vasoconstriction. So the clinical use to reduce what? To reduce hyperemia, to reduce edema, because it's used as nasal decongestion and open obstructed Eustachian tube. Then the adverse effect. This is the most important for pseudoephedrine and phenylephrine. What is the most important? Rebound congestion. It's called rhinitis medicamentosa. Which is called what? Rebound congestion if it's used more than 4 to 6 days. So leading to also what? Leading to hypertension. Why? Because of its effect on alpha adrenergic receptor, and of course associated with tachyphylaxis, and can cause CNS stimulation and anxiety in case of pseudoephedrine. So which one is so important in cases of pseudoephedrine, phenylephrine? The most important here is rebound congestion. In cases of activation of alpha adrenergic receptor in nasal mucosa, leading to local vasoconstriction, so it's used as nasal decongestion. But the most important side effect here is rebound congestion after usage of 4 to 6 days, which is called rhinitis medicamentosa, and of course association with hypertension because of its effect on alpha, associated also with what? with tachyphylaxis can cause CNS stimulation and anxiety in case of usage of pseudoephedrine. But you must remember in this case for pseudoephedrine and phenylephrine, rebound congestion.